Morning, everyone, and welcome to session number 4 for our mental health forum with Dr. Mark Browning, our special guest. It's been phenomenal thus far, and today I think is going to be even better. Every level, every session, as a matter of fact, we'll go probably to another level, and then culminate with the Q&A on next Friday. So we're almost done. Today, before we bring Dr. Mark on, I want to share just a biblical narrative, a real story in the trajectory of God's covenant people. This historical narrative dealing with the prophet in particular, and during a time of a great famine in 2 Kings chapter 6, where things had become so disparaging, people were taking unwholesome, ill-advised, and almost inconceivable moves for the purpose of mere survival. And in light of the current movements within humanity, we can see a lot of things setting people up for desperate measures, perhaps desperate responses, which will in fact serve as a breach within the context of our psyche and leave a lot of people reeling in the aftermath of ill-advised decisions because of just trauma. Sometimes natural disasters, when people go through gross loss, as Dr. Mark elaborated, there's some tendencies that are consistent that kind of prevail in the overall behavior. And he elaborately detailed those items the last session that we had. Like sometimes people can go into isolation, withdrawal, or they can retreat back to a previous time frame. Say a teenage child could go back to their early childhood development if a breach happens within their psyche that is a traumatic event or a violation of their person, and cause them to be arrested to that specific time frame. Or it could lead with drug abuse, just illicit behavior, ill-advised decision-making concerning one's physical person. But the story in 2 Kings chapter 6 is interesting because the famine was so intense that two women came together, and they actually practiced cannibalism and ate one of the children. And then the next day they were to do the same thing. It had become that intense and that bad. Now, many of you may say, well, my God, we're not in that predicament today. Case scenarios and situations carry tremendous significance when you think in terms of job loss, when you think in terms of the mental pressure, when you think in terms of societal demands, and when you think in terms of just global instability. These things all have a tendency to affect the way people think, how they perceive, and thus influence how we behave. And the natural disaster consistent with this great famine led to these extreme tendencies. Can you imagine the people who were aware of what these individuals were doing, the psychological ramifications it had on them in the context of their thinking? And so take some good notes. Let's tune in and listen well as we bring Dr. Mark Browning on to further help us delve into this subject of trauma, specifically dealing with our young people as well. So good morning, Dr. Mark. Good to have you with us again.
Good morning. Good morning.
All right.
Thanks for that word.
Okay.
I appreciate it. With that, we'll go ahead and get started. And Rika, if you wouldn't mind, we'll start with a brief video.
Mental health conditions are more common than you may think. 1 in 5 youth or young adults lives with a mental health condition. Do you know the warning signs? Like feeling sad or withdrawn for more than 2 weeks. Severe mood swings that cause problems in relationships. Intense worries or fears that get in the way of daily activities. Sudden overwhelming fear for no reason. Or seriously trying to harm or kill oneself, or making plans to do so. Not eating, throwing up, or using laxatives to lose weight. Significant weight loss or weight gain. Severe, out-of-control risk-taking behavior that can cause harm to self or others. Repeated use of drugs or alcohol. Drastic changes in behavior, personality, or sleeping habits. Or extreme difficulty concentrating or staying still. If you see these signs in yourself or a friend, tell a trusted adult. The first step to getting help is to say it out loud.
Good morning. Good morning. As you can tell a little bit from the video, our topic of discussion for today will be childhood and adolescent mental health. I think it's very valuable to obviously invest in the health, welfare, and well-being of our young people. They are struggling at a pace that's probably not been customary, like in our human history, with the number of challenges that they face, the access to information, the access to materials, adult materials that we've had access to in the past, the pressures to perform are taking a tremendous toll on our young people. So today we want to talk a little bit about adolescent mental health, some of the conditions that are prevalent with adolescents, some of the signs and symptoms we need to be aware of or consider and look out for, as well as some resources that might be helpful in helping us go in a direction of changing the trajectory if we do have young people who are struggling with some things, and looking at early intervention so that we might make the best possible decisions earlier and change the trajectory of some of the courses that some of our young people are on. So with that, if we can just jump into the first slide. So mental health, as we've discussed up until this point, has to do with our overall wellness, particularly in the areas of how we think and regulate our feelings and how we behave. Our behavior starts with our thinking, and oftentimes our thinking generates certain emotions, whether they be distress, and those thoughts come from the experiences that we have throughout our lives. So we want to look at how we come to conclusions, how we make our decisions, and the impact that our life and our life experiences are having on us. And those are all going to be influenced. Those outcomes are going to be influenced by a lot of factors: our genetics, our temperament, our intelligence capacity, things of that nature. So it's going to manifest in different ways with different people. Every person who has a similar or the same experience is not going to respond the same way. And we'll talk about some of those ways of responding today, particularly with children. Mental health disorders in children have to do with delays or disruptions in the developing age-appropriate thinking, age-appropriate behaviors, age-appropriate coping skills or social skills, and age-appropriate regulation of those emotions. So that issue of age-appropriate, I think we want to really kind of keep in mind when we think about how young people respond to circumstances. It is not unusual for, obviously, a 2-year-old child to experience tantrums and lose their cool when they don't get their way. That's developmentally appropriate. If that's happening with a 16-year-old, and it's happening with consistency, obviously that's going to be an area of concern. Or a 10 or 12-year-old being upset by being told no, or having things taken away from them. It's natural for them to be upset and maybe want to close themselves in a room for a short period of time. That's more unusual if we have someone who's older. So we want to keep the age appropriateness of and the developmental appropriateness of these kinds of behaviors in mind when we're considering what might be taking place in the things that that we observe in young people and in young people see in themselves. But treating mental health concerns, just real quick, we want to make sure that if we're seeing certain disruptive behaviors in our young people that are impacting their social functioning, their academic functioning, things of that nature, that we intervene early, because early intervention is going to be the best possible way of changing the trajectory that our kids are on. They have mental health concerns, have long-term and lasting effects well into adulthood. Maybe if we think about ourselves, the people we know, the challenges that they struggle with currently were likely in their infancy or beginning to develop early on in their earlier years. And maybe if we would have addressed those things, or if someone would have helped us, direct us in the right direction at an earlier point in time, we wouldn't be experiencing the degree of consequences that we experience as adults by making sure that we address these things early on. So treatment of mental health problems can reduce those problems that take place at school, in the home, in our relationships and relationship formation, and help us obviously in adulthood. And oftentimes therapy is a key component of that. I had mentioned, I think previously, that medication is sometimes of benefit, particularly with adults, can be as a benefit with children as well. But obviously we want to be conscientious about the use of medications with children and adolescents because of their formative development. But in some instances, when the impact of mental health concerns is significant, we may want to take that into consideration. And the combination of psychotherapy and medication management, research has indicated, gives us the best results. Next slide. If we could back up one. I think we need to go back to slide 2. So there are particular mental health concerns that we see in children. So these are ways that mental health concerns manifest in our young people that maybe they're similar to adults, but maybe a little different because of the developmental stage. One of the first is the issue of anxiety, which is persistent fear, worry, or anxiety that disrupts a person's participation in school, in social activities, and things of that nature. Some children and adolescents respond to the circumstances in their lives or their experiences with overwhelming fear, and we'll get into some of the particulars of those. Sometimes we'll see ADHD, or what is termed attention deficit hyperactivity disorder, which is exemplified in pretty significant lapses in attention, the presence of impulsive and disruptive kinds of behaviors, hyperactivity, or an inability to slow down, or sort of a frenetic way that a child responds, where they can't regulate their energy level and slow down enough to really kind of pay attention or be engaged in certain activities, or a combination thereof. Attention deficit hyperactivity disorder may consist of primarily inattentive symptoms in which children can't stay attentive, can't concentrate, are forgetful, things of that nature, or it may be exclusively kind of hyperactive, in which there's a lack of self-control, or maybe a combination of the two. One we maybe don't talk about as often is autism spectrum disorder, which consists of sort of it's a neurological condition that consists of difficulties in communication and interaction. We'll find young people who maybe don't understand the nuances of social interaction, that they don't get or understand humor. They may be more sort of concrete in their understanding of information. They take information literally. There may be a difficulty with tolerating stimuli like loud noises or strong lights. They may have real significant sensitivity to that. There's sometimes a self-soothing in which people rock or engage in rocking motions to kind of help themselves calm down when under distress. There may be an insensitivity in interaction because they don't understand social nuances. So they may say really hurtful things with a lack of awareness of how that that communication lands on other people. We're seeing more and more of that in our practice, more struggles, which I'm not sure may be in part due to the significant amount of technology that we ingest now. But there's some research on that, on some of the causes beyond sort of genetic or neurological. We may see young people respond with eating disorders, a preoccupation with an ideal body image, or disorder thinking about eating and about weight loss. Symptom characteristics like anorexia nervosa, which is self-starvation. When people see themselves in the mirror as being large or overweight, even though they're thin, and so they will go to extreme measures, restricting their diets to access an ideal body image, or bulimia nervosa, in which they will go long periods without eating and then binge eat or consume excessive amounts of food, usually in secret so that other people can't see, and they'll be followed by the guilt and shame that comes with that, and binging and purging. What we call binging and purging, purging of making yourself vomit to expel all the food that you've taken in due to either discomfort or shame or things of that nature. And some young people respond that way. The depression and mood disorders that we talked about previously, persistent feelings of sadness, loss of interest in a way that disrupts our functioning in school or in our family life. Post-traumatic stress disorder, which is prolonged emotional stress and anxiety, characterized by distressing memories, nightmares, disruptive behaviors that are generally in response to some kind of trauma, violence, injury, some sort of form of traumatic event. And then schizophrenia or psychotic disorders, in which people respond with a loss of connection with reality, disordered perceptions in which they may see or hear things that other people don't hear or aren't actively present, or be preoccupied by what we call internal stimuli, conversations or interactions that are taking place in their head that aren't privy to other people, that are consuming them and distracting their attention. Delusions, which I think we touched on briefly maybe in the first session, really beliefs that aren't based in reality, believing they're maybe under surveillance, that people are watching them or surveilling them, or things of that nature, or grandiosity in the sense that they feel like they have unusual power, strength, skills, capabilities, and aren't able to relate to other people. So people respond in different ways to the traumatic experiences that they have, to the stresses that they experience in day-to-day life, things of that nature. And these are some of the ways that they show up in adolescence. Over the next few minutes, I just want to delve a little more deeply into some of the conditions that we see and how they manifest, that we might have an idea of what kinds of things to look for, and what kinds of things may need the attention of a professional, but at the very least need our attention and our signals that our young people are in a form of distress that they might not be able to effectively articulate to us, but their behavior is a communication to us that I believe that we need to pay attention to, and sometimes rises to a level that needs professional intervention. Next slide. So I'll just kind of move through these a little more succinctly. The anxiety disorders are really the primary disorders that we're seeing in our young people in this day and time. Those feelings of apprehension or uneasiness or uncertainty or dread about the future, or misfortunes or concerns that we get preoccupied with taking place in the future. I think it's important to keep in mind that anxiety is painful. You think about your own sort of worry and concern about performance, or are things going to work out all right? And those are manageable. We can problem solve in a way that we We can either talk to people or make decisions or problem solve in a way that can help diminish that anxiety or worry. We're talking about anxiety that is overwhelming, where the fears are so extreme that we come up with, or we respond with unhealthy, counterproductive ways of responding to help navigate that anxiety, ways to decrease or diminish it, so that we can get ourselves to a baseline or a feeling of peace or comfort. And these responses are unhelpful in the sense that if they're effective at all, they're effective only sort of momentarily. They don't give any sense of long-term relief, and subsequently are oftentimes repeated as a form of adaptation that brings more problems than it does resolves the anxiety. So some of the ways that we see this manifesting is in what we call specific phobias, or persistent or irrational fears of objects, activities, or situations. These are the fears of heights, the fears of crowds, fear of different animals or spiders or things of that nature. A lot of our anxieties are then put into a particular object, place, or circumstance, and it dictates our lives, because we then sort of orchestrate our lives to avoid these situations, which isn't oftentimes possible if we want to live healthy, effective lives. Some people respond with what we call panic disorder, which is a sudden onset of extreme fear or apprehension, a sense of impending doom, as if that death is around the corner. There's sometimes we suppress our fears or things that concern us, and then they manifest in these profound sort of rebounds in which we our heart starts to race, we hyperventilate, we begin to perspire, we feel like death is imminent. And it can give us a sense of having a heart attack or some kind of cardiac condition. Very, very real sense of panic that sometimes people respond with, related to the fears they experience. Agoraphobia, fear of leaving the home, or fear of being in a place for which there's no escape. There are more generalized anxiety disorders in which there is excessive or persistent or uncontrollable fear, anxiety, or worry that just is broad-based and spans most every arena, whether we're in school or whether we're with our friends in public or whether we're at home. It's just a broad-based fear that sometimes can overtake us and interfere with the way that we function. Or things like obsessive compulsive disorders, in which there's persistent recurring impulses or images that take place in our head that we can't seem to get rid of. The obsessions are the preoccupations with those particular things, whether they're preoccupations with cleanliness or with order or with safety and security. And the compulsions or the compulsive aspect of that are sort of combined ritualistic behaviors that we feel driven to perform that help to reduce that anxiety. So I guess the classic example is sort of the ritualistic hand washing that you may sometimes hear about or see or be aware of, in which a person is obsessed with germs or cleanliness. And because of that, it raises the compulsion of hand washing. And so the hand washing helps to diminish or alleviate some of the fear and angst surrounding that. But by the same token, it's minutes, sometimes hours, sometimes moments before the anxiety rises again, causing us to repeat the behavior to help diminish the anxiety, but it never really goes away because the issue that's stimulating the anxiety is never resolved. And so the compulsive behavior then becomes disruptive to the remainder of our lives, our ability to function, because not only are we preoccupied with the thing that is worrying or concerning us, the compulsion to repeat the behavior is disruptive to our lives and activities. And so these are some of the ways that we see the issue of anxiety kind of manifesting in young people. We talked a little bit about attention deficit hyperactivity disorder, in which there are attention problems and hyperactivity that shows up in low frustration tolerance, temper tantrums, things of that nature. One of the disorders that not necessarily a disorder, but some of the things that we see in our young people are disruptive sort of what we call the disruptive behavior problems, which are conditions that are characterized by problems with self-control, problems with emotion, and problem with behavior, particularly those in which undermine the rights and privileges of other people and go against societal norms. So some of those include what we term oppositional defiant disorder, which is a persistent pattern of negativity, disobedience, defiance, or hostility that's directed towards authority figures. So in this disorder, we will find young people who can't seem to accept direction or can't accept limits or authority, that they see it as a violation of their own personal rights and respond with that, varying from a very aggressive behavior towards those who are in authority or attempt to give direction or provide or set limits, down to just consistent obstinance and opposition, refusal to respond to any kinds of limits or directions or orders, which is not unusual sometimes to see in people who have experienced traumas in which they have their own rights violated, and feel like the world doesn't have their best interest in mind, and they need to not only be fearful of authority and protect themselves with anger or aggression or opposition, but feel like they know what's in their own best interest, and no one has the right to tell, suggest to them what should be done that's in their best interest. So another disorder is intermittent explosive disorder, in which there's very, very poorly controlled emotion, outburst of angers, and these outbursts or lapses in emotional self-control are disproportionate to the interactions, the interventions, any of the provocations that they experience. People are young people who, when you set normalized standards on them, things that are completely within the realm of expectation, it's responded to with an explosive type of episode, almost walking on a landmine, that you can be walking through an area that seems completely benign, but when you hit that trigger, that the person just explodes, and you question what is it that created or stimulated that response. We can oftentimes see that in young people, that a profound sense of poor emotional or a profound sense of emotional dysregulation that comes in response to what we see as somewhat kind of benign circumstances. We may see what we call conduct disorder, which is a persistent pattern of behavior in childhood or adolescence, in which the rights and privileges of others are violated and societal rules and norms are violated. And this goes across settings, whether it's in family life, whether it's in school, whether it's on a job that they're in, whether it's in any extracurricular activities, whether it be sports teams or clubs that they're involved in. There's this prevailing pattern of taking advantage of other people. And we see this as kind of a precursor to antisocial behavior. It's pretty significant and needs to be addressed and needs our attention. Obviously, because behaviors like this you said, our young people on a really significantly negative trajectory. And once behaviors like these can obviously land them in the juvenile justice system, in which there is going to be less concern about their mental health and well-being, and we can get on a pattern in which these kinds of consequences obviously influence our ability to function effectively in society. It sets up more barriers, more limits, more consequences in the future if it doesn't get addressed early on. And then obviously there's the depressive disorders in which our young people are sad or feel empty or irritable, and may have somatic complaints or cognitive complaints because of the feelings of despondence or feeling this sense of hopelessness in their lives, like things aren't going to get any better. And we touched on this a little bit in the beginning, things like major depressive episodes, persistent depressive episodes that are more characterized by irritability rather than sadness or despondence. And that's more customary for our young people. The depression in our young people has a tendency to manifest more as irritability and anger and temper outburst, in part because they oftentimes can't or aren't willing to articulate what it is that's taking place within inside their heads and their bodies, whether that's developmentally, whether it's cognitively. There's much more of a tendency to sort of act out how we're feeling internally than there is to be able to say or document how it is that we're feeling. Disruptive mood dysregulation disorder has been more common in our young people, probably more so than the major depressive kinds of episodes, in the sense that there's a chronic sense of irritability or frustration that takes place with our young people, characterized by frequent temper outbursts, like more than one or two a week, just really frequent, 3 or more during the course of a week. But also in between those times, the person is between the times of the temper outbursts, there is more of a sense of irritability, particularly if we see this over the course of a year. If the baseline for our young person is that they have a pretty a jovial disposition, or they are agreeable, and are really kind of more sensitive and kind and engaging. But we see over the course of 6 months to a year that their consistent mood from day to day, most of the day, is more irritable and frustrated. Then there may be an indication that there's more going on than just the customary kinds of irritability that takes place with us as people, and as young people, because obviously we're aware developmentally that our kids are probably more prone to episodes of low frustration tolerance or being irritable. It's customary for adolescents. So, but if this is going on for longer and longer periods of time and is a significant variation from what their customary character is, then that's usually an indication that there's something that's taking place that needs our attention. Next slide, please. I think, as difficult as a topic it is, I think we'd be remiss if we didn't talk about young people and the issue of suicide. Suicide being death caused by injuring oneself with the intent to die, and talking about suicide attempts, which are attempts to harm oneself with the intent to end a life, but not dying as a result of that. Suicide is taking our young people at alarming rates currently, and I don't know if it's a sign of the times, that because we live in such sort of chaotic and distressing times, or if it's some of it has to do with the pressure, either externally or internally, that young people are feeling, not only to perform, but to have their life mapped out at an earlier age to meet certain expectations. I think, I don't have a big social media platform, so I don't maybe am as not familiar with some people, but the issue of social media obviously is having profound impact. The shallow relationships, I think, sometimes that are built that don't reflect deep connectedness that I think that we are our need and require for our well-being. The needs to be liked, any neglect that maybe takes place in those platforms. Obviously, the bullying that can take place in these platforms. Access to information. I mean, I just think about it kind of concretely. When I was young, the television used to go off. We had 5, 6, 8 channels used to go off at night. So you had to go to bed or figure out something else to do. And now we have 24-hour access to information, entertainment. People have 24-hour access to us. Well, if you called my house after 9 o'clock when I was young, you had a problem. My father wasn't having that. And now with the access to cell phones and laptops and tablets and things of that nature, we have 24-hour access to each other. So it's hard to get away from people, to have downtime, to have quiet time. There's so many things that our young people are dealing with at this age. Adult content is more accessible. There's just so many challenges that our young people experience. Not to mention the customary challenges of adolescent and forming an identity, things of that nature. So there's a tremendous amount of pressure, and a lot of our young people are responding to that with a sense of hopelessness and despair, and as though things aren't going to get better, and this is the way things are going to be, and if it's going to be like this, I might as well end it now, because I can't tolerate my life being like this further. So we really need to be attentive to what our young people are going through and what they're experiencing, and paying attention to the signs and symptoms that we'll talk about a little bit. But statistically, suicide is the 10th leading cause of death in the U.S. overall. It's responsible for 2018, it was responsible for 48,000 deaths, which amounts to about 11 a suicide death every 11 minutes, which is very alarming. And it's the second leading cause of death for those aged 10 to 34. So that's a little bit of an indication of the impact that it's having on our young population. And the consequences, obviously, are not just to our young people. Family members of those who have committed suicide experience a cascade of emotions: shock, anger, guilt, depression. The ripple effect of a suicide in a family is astronomical, not only in the intensity in which it impacts the people who are directly affected, but the rings that it goes out to everybody who was involved with that person and involved in that person's life, who cared about them and was connected with them in some way, shape, or form, are profoundly impacted by suicide as well. And people being left not only by the loss of that person, but by the feelings of guilt. Why didn't I recognize what was taking place? What could I have done? Was there something that I did that was responsible for it? It has a profoundly negative impact on survivors. The injuries from a suicide attempt can be long lasting, not just from a physiological standpoint and the injuries that take place from that episode, but also the profound emotional consequences that people can experience after a suicide attempt, in the event that it was not completed, can be profound and detrimental. Even those who are survivors and who have a lived experience of having a person in their family or in their circle who has committed suicide raises their potential risk for suicide as well. I have clients and have had clients in the past who have had family members who had completed suicides, who are struggling with their own sense of, is a life worth it or not? And so the effects of suicide are far-reaching, and need immediate attention for anyone, but in particular for our young people who may be experiencing a sense of hopelessness. Next slide, please. So we want to be obviously attentive to the potential risk for suicide. There are what we call immediate risks, which can be an indication that a suicide attempt is imminent. Circumstances like the person talking about wanting to die or talking about wanting to kill themselves, looking for ways to kill themselves. Some people sometimes research ways in which they can do that through either medications or some other means, or attempt to access firearms or other lethal means of taking their lives. Talking about feelings of hopelessness or not having a reason to live. These are the more warning signs of more imminent risk of suicide, and should be responded with calls to a call to 911 or emergency medical services, contact with the National Suicide Prevention Hotline, 1-800-273-TALK, or 8255. I think we were on the banner at the bottom in the event that anybody needs that, or seeking out a mental health professional. One of the things that we do in our agency, we have our assessment and referral center is there for free and confidential, what we call level of care assessments, in which you meet with a licensed professional who can do a more in-depth assessment. One, obviously, to assess for suicide risk, but to assess for an appropriate level of care. Would this person benefit from traditional individual outpatient therapy with a counselor? Would they benefit from what we call intensive outpatient or partial hospitalization programming, which is group-oriented programming that works from 3 to 6 hours a day, either daily during the week or 3 days a week or something along those lines. Or is the person at imminent risk and requires inpatient hospitalization to ensure their safety or security? But I imagine that there are a number of our hospitals in the area, either through their emergency room or some other means, have these particular services where we can do level of care assessments to ensure that we're putting people in the appropriate place to get the care that they need and set them on the right trajectory. Serious risk, not imminent, but serious, obviously always needs to be taken seriously, includes warning signs like talking about feeling trapped or being in unbearable pain, talking about a feeling as though they're a burden to other people, that other people's lives would be better if they were no longer around. Significant increases or starting the use of drugs or alcohol, increased anxiety, agitation, or reckless kinds of behaviors in which people are making decisions or acting out in ways that indicate a lack of care or concern for their well-being and their safety. Sleeping too little or too much, withdrawing from interactions, withdrawing from the friends group that they're generally with, withdrawing from family functions, withdrawing from interactions with people who have always been important to them in the past. Episodes of rage or talking about seeking revenge or retribution for slights, oftentimes slights that don't warrant responses like that. Or extreme mood swings sometimes can be an indication that the person is at risk. But I think any of these warning signs are an indication that something is amiss. I think the way I kind of look at it, kind of a simplistic frame that I use, whether it's with family members or friends, is if someone's acting out of character, if their customary character is one in which they're social, they're agreeable, or maybe they're even quiet and withdrawn and more introverted and introspective. But the behaviors that they're displaying are significant variation from the character that they customarily um, 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 show, then I think that's probably the first sort of indications that there's something amiss and that there's things that are taking place in their lives that maybe warrant some attention and maybe on the course of maybe not necessarily a mental illness, but a deviation in character that can have consequences for them in their interpersonal lives or the things that they're invested or involved in. Next slide, please. So I'll move through these in the service of time, but therapy obviously is a helpful resource for people who are struggling and a source of support for family members and friends as well. One thing I think that we want to understand that oftentimes these are not individual problems. When someone's experiencing a mental health concern, though the behavior is being manifested in that person, we talk a lot about what we call in psychology the identified patient. And what that is there's usually somebody who's carrying sometimes the dysfunction that takes place in a family or in a community or in a group. And that person is sometimes manifesting a bigger sort of set of concerns that's taking place in the unit. So oftentimes it's very important for us to be involved and invested not only in the care of the person who's experiencing these concerns, but our own education, awareness, resources, and willingness to assess what may be taking place in our circle that's impacting or influencing this person in this way. But in the interest of therapy, sometimes parent training and behavioral management is helpful, a way of to work with parents and learning to improve the skills in managing children's behavior or understanding their behavior better in a way so that we can respond effectively, that we're responding with the right sorts of interventions when a child is experiencing certain concerns. Child behavioral therapy, which teaches children and families how to strengthen positive behaviors or reduce or eliminate unwanted behavior problems. Cognitive behavioral therapy, which focuses again on looking at our thinking and managing our thinking and emotions, or the kinds of thinking and emotions that impacts our behavior and subsequently the consequences that we ultimately experience. These are all really very helpful in addressing disruptive behavior disorders, anxiety, depression, and obviously trauma. Next slide, please. So we wanted to just post some resources for a minute that are ways that we can, or sites that we can go to that will help us not only find the resources that we need, but to find resources in our particular areas. I know the audience is coming from a lot of different geographical areas in and around Chicago and around the U.S. So many of these resources I think would be helpful in locating services in these areas, where at the very least you can ask questions and get an understanding. You can tell the providers or those representatives what kinds of things you're observing, what you're experiencing, what your concerns are, and at the very least get some direction regarding next steps, and finding resources that may be beneficial. With anything, I think just like with a physician office, this starts with good, thorough assessment, and not only assessment for suicide, but assessment for what kind of conditions we might be experiencing, and understanding what it is that's taking place so that we can address the correct concerns, that we're addressing the appropriate issues that are being experienced by our young people. And with these resources, we want to make sure that if we're working with children and adolescents, that we're looking to access child psychologists or specialists in child and adolescent services, and that we're addressing child and adolescent psychiatrists if medication management is going to be an issue. We want to ensure that we are connecting with people whose specialization is with children and adolescents. They're children and adolescents. They're not just small adults, obviously. Their developmental stage is different. Their neurological development is different. The developmental stages that they're in are important. So we want to be ensure that we're working with someone who specializes in the area of children and adolescents, and that we don't get someone who is just overlaying adult kinds of treatments and interventions on adolescents, thinking that that's going to be effective. It's not going to have the kind of effectiveness that we're looking for. So with that, I think I'll bring my portion to a close and bring Apostle back in. And I hope that gives us at least a cursory indication of what our young people might be experiencing and how we might be able to see the signs that'll be beneficial for us to start putting us on a better trajectory.
Wow. I'm still stuck on some of the disorders, Dr. Mark, one in particular, it's just like, once again, I think the information that you're sharing is, for, at least from my perspective and just sphere of influence, is providing context for things that I've witnessed perhaps on a regular basis. Some of the stuff even in my own family. I think I'm probably I'm one of the identified patients. Yeah, I saw myself in that too. But the one that really alarmed me was the depressive disorder that actually leads to suicide, and how, like, in 2018, the stats alone, every 11 minutes, there was a documented suicide.
Yes.
Then the demographic affected by it, which just really highlights the fragility of our society when it comes to managing mental illness. And you started the conversation along these lines about how our thought lives will oftentimes determine our physical well-being.
Absolutely.
It begins with the thought. And there's a powerful scripture that talks about, as a man thinketh, so is he. And sometimes how, you can't really visualize what's going on inside of a person's mind. And one of the impending issues with social media and how it disrupts the natural order of physical interaction.
Yes.
In fact, can exchange ideas, and a bonding can actually kind of take place to help affirm people just by way of physical presence. And that there's a void that's there as well.
Yes.
Yeah. And it's just like, wow, we just have so much. It seems to be like ahead of us, but I think this is a good seedbed moment for those who are tuning in, parents in particular of younger children, even adult children, and just looking at how, okay, well, maybe I was a codependent, or even a facilitator of the behavior as an independent or identified patient, and not knowing what I was dealing with, and then responding in an inappropriate way. Wow. Wow, thank God for all people involved in the mental health. You are a tremendous asset. We greatly appreciate you, and I trust you. The audience that was able to spend time with us this morning was extremely blessed as well, and won't hold any longer. Once again, we appreciate you. Thank you so much. This was very wonderful. Yeah. So we got 2 more sessions left this Monday, and then next Friday will be the Q&A segment to finalize the program. So make sure you get those questions in. Once again, we'll do our best to try to cover as many as possible within the allotted time frame. And then please take note, go back and review this. At the end, there was a list of resources that you can in fact go to get help. That's kind of more on a national basis than tailored to a specific plot of geography. So yes, Dr. Mark, thank you. Have an amazing Friday.
Hey, you as well.
Yes. Okay.
All right. Be blessed.
All right. God bless.